Good evening, ladies and gentlemen. Welcome to another free sample question solvation class with First Aid AMC course. Let's just wait a couple of more minutes before everyone can join, and then we will start a free session class today. Please note that this session will not be streamed live on Facebook. So if you want to inform your friends, just tag them in the comment section of the Facebook post with the Zoom login ID and password, and they can join the class today. It is a free session, but unfortunately, it won't be live streamed on Facebook today. Let's just wait a couple of more minutes before everyone can join, and then we will start the sample question solvation class. All right. So let's start our class today. Welcome everyone to another free recall sample questions session with First Aid AMC course. For those of you who haven't attended the class yesterday, a bit of introduction about the First Aid AMC course. So AMC is an exam for Australian health system practitioner, and it consists of two parts. There is an MCQ exam, which is multiple choice questions, and then there is the clinical exam where you have to perform um, uh, in different stations. So for first aid AMC MCQ course, if you subscribe to it, it will consist of at least 5 months of studies with us. The main course coordinator and tutor is Dr. Arshan. He will be covering all the theoretical part of the exam, especially which includes general practitioner or family medicine, internal medicine, surgery, general surgery, orthopedic. Sorry, my throat is not. It's a bit hoarse today. So let me know if you guys are unable to understand what I'm saying. What I was saying, internal medicine, general surgery, emergency medicine, gynae and obstetrics, and pediatric, and also the screening part of the exam as well for the cancer. So he will be covering the theoretical classes, whereas I'm one of the tutors. My name is Rabia. Along with other two tutors, we will be taking sample question solvation classes every week, which will be sometimes two classes per week or one class per week. And all of these will have recordings available on the software. Once you subscribe to the course, you will be granted access to the set course software, and you will be able to, if you can't attend the class, for example, due to your special circumstances or because you're in a different time zone, you will be able to access the recording of the class on the software. Once the class is finished, it will be uploaded there along with the notes. So my job as one of the tutors associated with first aid AMC course is to help you guys get equipped with the knowledge about the tips and tricks used to solve the questions in your exam. There will be 150 questions in your MCQ exam, and you will have approximately, I think, 150 minutes, or I think 2 hours and 50 minutes, something like that. So in this way, you will be able to at least get a good grip on time management in your exam. Number one. And number two is that we will help you guys focus on the key content within the MCQ that can help you solve the MCQ question really quickly so that you can save time in your exam and complete the exam. Because once your time finishes in your exam and you haven't attempted the questions, your exam will be null and void. It won't be marked. You will be marked as fail. So time management and making sure you attempt every question is imperative for you to pass the exam as well. It is quite possible exam, AMC, MCQ question, but the thing is, Australian health system is a bit different to, especially the health practices in subcontinent region. So they are very strict in following the protocols and guidelines in managing the patient. So if you are well aware about the basic knowledge and are aware about the Australian health guidelines as well, it will be easy to pass the exam. And sometimes students ask me, what is the level of difficulty in this exam? It's like every exam you have done in your life. It will contain some of the easy parts, some of the parts will be quite tough, and some of the parts will be having moderate level of difficulty. So the difficult question part will determine whether you pass or not, because majority of the students are able to attend the easy questions and moderate difficulty questions, but the difficult questions will basically put you over the line of passing or not passing the exam. So let's start our class today. These are the sources, as I discussed yesterday, that we use in our sample question solvation class. So John Murtagh, it is a book with the latest edition. If you have this John Murtagh, like I think the latest edition is 9, then it's imperative. It's the basic book that you will study for making your basic knowledge well for passing AMC MCQ exam. Now the guidelines that we use is the Royal Australian College of General Practitioner, Royal Children's Hospital, SA Health for obstetric and gynae, New South Wales, Queensland Health, and Victoria Health. So these are also state-based, but sometimes some topics are well explained in the guidelines in one state. So we try to give the guideline that is quite comprehensible and is practiced generally everywhere. We also use Kaplan and MedBullets. Kaplan for general surgery, MedBullets for hematology and orthopedic cases. All right. Now let's move on to the first question. If you don't attempt a question, then your exam will not be scored and you will be marked as failed. So it's imperative that you need to attempt the 150 questions. MedBullet book, Dr. Gabayu, it's a source that can be found online as well. For AMC MCQ, there is only one class today. The other class is for the clinical examination. So please join the class whose link has been given in First Aid AMC MCQ Facebook page, okay? Alrighty. First question is from pediatric age group. A child of 6 years presented with 1-day history of acute earache and high-grade fever and presented in emergency. You are intern on duty. Sometimes they will use the term JHO, which is junior house officer. Sometimes they will use the term SHO, which is senior house officer. Both are residents. Sometimes they will use registrars. Registrars are trainees. So most of the time they will ask you questions about that. They never ask you about question related to registrar level because this is an entrance exam. A child of 6 years presented with 1-day history of acute earache and high-grade fever. So young child having earache and high-grade fever, acute presentation in emergency, and you're a junior doctor on duty. What do you want to do next? Give IV antibiotics to this child, give analgesia/antibiotics, give oral antibiotics to this child, or admit them in the hospital. So this question is basically about a common problem which is encountered in emergency department, and it helps you to triage whether this patient needs to be admitted, whether this patient needs antibiotics, or whether this patient can be given something and sent home after doing safety netting in the patient. Can anyone tell me acute earache and high-grade fever, what could be the differential cause for the condition? Acute otitis media, very well. So this patient is suffering from acute otitis media with earache and pain, but there is no discharge. So whenever a child is having first presentation in the hospital with ear pain and fever, we don't do anything other than examination of the ear. We don't do anything. We just give them analgesia and antibiotics for the first 48 hours. If the patient does not respond to analgesia or antibiotics in the first 48 hours, meaning their fever is not coming down, their pain is not settling, then we ask them, if it doesn't settle, please present again within the 48 hours for review and for giving oral antibiotics/IV antibiotics depending upon the septic state of the patient. All right. Is it clear, guys? intern can treat patient, Dr. Kaboya. They do have the authority to treat the patient. Yes, they need to discuss with the senior, but they can treat simple conditions. So here the correct answer is analgesia and antibiotics. Let me share this slide with you guys. This is our RCH flow chart for acute otitis media. So if a child is presenting he or she is mildly unwell and they have no red flags. First of all, focus on the red flags. So if they haven't mentioned about any of these red flags in the question, then treat the patient with analgesia. All right, for the first 48 hours. What are the red flags? If they have mentioned that the child is less than 6 months of age, or immunocompromised, or belongs to Aboriginal and Torres Strait Islander, these are the indigenous communities of Australia, has only one ear, has an implant in the ear, and might be discharging purulent discharge from their ear, then these condition, all of these present together or present individually, requires immediate treatment with antibiotic, which is amoxicillin, 30 milligram per kg per dose, twice daily for 5 days. All right. If we are sending the parent home, you need to give them a handout as well. So there was no red flag in our question. So we would just give analgesia and no antibiotic for the first 48 hours. But if any of those red flags are present within the question, then you need to give analgesia with the antibiotics. Okay. Symptoms are improving, then you advise them parents to seek medical review of the ear and ask the GP to do like a formal audiological testing, right? If the symptoms are not improving in the patients with the red flag, then you can switch to augmentin or amoxicillin clavulanic acid 22.5 milligram per kg per dose BD for 5 days, or you can discuss with the specialist. During my class, I would request you guys to keep your mics mute because it creates a kind of disturbance and it slows down the rhythm of the class as well. If you guys have any query, I would encourage you guys to write it in the chat box. I will read all the comments. If I'm not reading any of your comments, just flag with me and I will try to focus on that and try to answer your queries as well. All right. Any question from this slide, guys? Alrighty. So if they have mentioned any of the red flags, are if they are together or individually present, please choose antibiotics. Okay. Also, when they will mention the red flags, they will also mention about the hemodynamic stability, or they will give clues about the sepsis or not. If they have given you clues that they are having fever plus less than 6 months of age, or Aboriginal or Torres Strait Islander children, or they say immunocompromised, so you have to choose oral antibiotics versus IV antibiotic as well. All right. What's the treatment in suspected viral otitis? Viral otitis, Dr. Sandra, is the most common cause of acute otitis media. That is why in the first 48 hours of any child presenting with acute ear pain and fever, we just give paracetamol and ibuprofen. Okay, because most of the time with viral otitis, virus is the cause of the otitis media and it responds quite well to the analgesia/antibiotics. What if there is amoxicillin and augmentin with red flag? No, they will not give you together. They will give you either that they have tried amoxicillin, what is your next drug of choice, or they will give you only amoxicillin with other drugs in the question. They will never give you together unless one is the particular answer. Why Aboriginal counted in red flags? Because Aboriginal communities in Australia, they don't they It's because of the culture. It's not because of education, but because of the culture. They don't do follow-up with their doctor, so they will come to doctor only when they feel like that the child is not responding to anything. Then we have to opportunistically give them antibiotics to prevent complications, because complication happens a lot in their community as well. So to prevent deafness or chronic otitis media, we will give them antibiotics to prevent those complications in future. Is it clear, guys? Yes. So in case of aboriginal, go for antibiotics straight away. All right. Next question. A patient, 26 years old, presented with upper respiratory tract infection, also has 1 plus proteinuria and hematuria. So 1 plus hematuria and proteinuria in the urine. After 2 weeks, she came back for follow-up. Everything is normal on the examination. What do you want to do next? Reassure, ultrasound kidney, urine analysis, or renal function test? So this is a patient who is 26-year-old, had a ERT infection, had some proteinuria, very mild proteinuria, very mild hematuria. After 2 weeks, she came back for follow-up. Everything is normal on examination. What do you want to do next? Reassure, do ultrasound kidney, urine analysis, and renal function test. All right, so majority is doing C. Very good. Why we want to do a urine analysis / urine microscopy culture / urine dipstick? Why do we want to do it? Because we want to see whether they have proteinuria or hematuria persistent after resolution of the upper respiratory tract infection. Because if they have mild proteinuria with persistent worsening hematuria, patient might have PSGN or glomerulonephritis or nephritic syndrome. Very good. So we always do a follow-up urine analysis or urine microscopy and culture. Okay. Everything normal on examination means vitals and clinical exam. So there is no rising blood pressure and early exam. They might have done a chest examination. Everything is normal. So patient has completely resolved this infection. When the patient has complete resolution of infection and incidental finding of proteinuria and hematuria during that infection, we always do a follow-up urine analysis to make sure that this has gone or resolved or not. Okay? Is it clear, guys? Because in young patients with the sore throat or skin infections can lead to glomerulonephritis. So your answer is urine analysis. Look at this one. It's the same that we did yesterday. So we have to make sure if hematuria is there, we have to make sure urine microscopy and culture is done. All right. Next question. When they say exam in this case, exam does not pertain investigation, Dr. SP. Exam means physical examination and vital signs. All right, next question. A man in 50s complain of numbness in the feet. He can't walk in the darkness because of balance problem. He is strictly vegan. looks pale on examination. So two big clues they have given in your which investigation you want to do next. Vitamin B12, CT head, MRI brain, nerve conduction studies, and anti-cholinesterase antibodies. All right. Everyone knows because he's vegan, looking pale, and has numbness in the feet along with coordination and gait problem. This is vitamin B12 deficiency, most likely leading to subacute degeneration of the cord, combined degeneration of the cord. So, absolutely right. This is the answer. Now, for those people who don't know how to reach this answer, number one, if the patient has, let me just mute. I can hear voices in the background and it just breaks my concentration. All right. 50-year-old complaining of numbness in feet and can't walk. If it was still there, they just complained of neurological symptoms, and haven't mentioned that he had nutritional deficiency and looks pale on examination. We would have done which imaging straight away? Which imaging would you do if there was only neurological symptoms mentioned? MRI, Dr. Arif, it's not easily available. CT, we will do CT straight away. Why do you want to do CT scan? Why? What is you want to rule out straight away so that you can start treatment? What do you want to rule out in a patient who is having acute neurology? Yes, very good. We want to rule out stroke, hemorrhagic / ischemic, right? We want to rule out stroke because 50-year-old patient who is having acute neurological features, we want to rule out stroke by doing CT scan, right? MRI brain, we will do later if we can't see anything on the CT and there is persistent neurology present and it hasn't resolved. Nerve conduction studies are done when there is isolated peripheral neuropathies. Okay. If it was just numbness in the feet associated with foot drop and the rest of the examination, neurological examination was absolutely normal, then you would do nerve conduction studies. Or the patient is complaining of just weakness in one arm associated with numbness, then you would think of, oh, there might be something wrong with the plexus, or there might be some peripheral neuropathy going on. Anti-cholinesterase antibodies. Can anyone tell me in which condition we do these serology tests for diagnosis? Anticholinesterase antibodies, very good. Myasthenia gravis. Now, myasthenia gravis, is it an ascending paralysis or a descending paralysis? It's a descending paralysis from top to bottom. So it will start with like problems like vision because there will be ptosis of the eyes. Number two, they will have problems with swallowing and speech difficulty. They will feel tired at the end of the day. They will have weakness of the upper limb as well. So descending paralysis. Ascending paralysis from bottom to top happens in which syndrome? Guillain-Barré syndrome. Okay. Always remember Guillain-Barré syndrome from bottom to top, myasthenia gravis from top to bottom. So we do these serology tests in myasthenia gravis. As we know that in this situation, they have given a big clue about their diet and the patient being pale. So we would rule out vitamin B12 deficiency. I cannot emphasize enough how common this is in the elderly population. It's quite common. So not only diet cause it, excessive use of PPIs, excessive use of alcohol, very good, Dr. Maria, gastric surgery, autoimmune disorders, and use of metformin. These can also lead to vitamin B12 deficiency as well. Does myasthenia more common in males and females? So it's more pertaining in females, but if you look at the randomized controlled trial that was done in, I think, 2021, it says equal incidence in females and males. Okay. Any question, guys? So as I said before, I take most of the hematology questions from at bullets because it will have something that is like a question as well. Also very detailed. All right. So if you look at the question over here, are you guys able to see the screen? Let me just check quickly. All right, you guys are. So a 55-year-old man is brought to his primary care physician by his wife for increased confusion. He forgot to turn off the stove after cooking and frequently misplaces his keys. So altered level of consciousness is there. He fell approximately 1 week ago while walking in the dark. His physical examination is notable for short-term impaired memory, decreased vibration, and proprioception. Yeah. And patellar hyperreflexia. On lab investigation, he has macrocytic anemia, reticulocytopenia, and low serum vitamin B12 level. Okay. So we know that vitamin B12 deficiency is involved in megaloblastic anemia, causes reversible dementia, and subacute combined degeneration of the cord. Can happen because of the decreased oral intake, which is like which is a strict vegan diet, breastfeeding in a vitamin B12 deficient mother, because the bub will take all of the vitamins from the mom, decreased animal product intake as well, decreased absorption, like bariatric surgery or gastrectomy, Crohn's disease, celiac disease, pancreatic insufficiency. Very important for you to remember. I remember there was I think in my exam, this question came, which parasite is associated with vitamin B12 deficiency? So Diphyllobothrium latum is a fish tapeworm. This is associated with vitamin B12 deficiency. Or gastric atrophy. Medications like PPIs, histamine receptor antagonists, and metformin, and autoimmune disease, which is pernicious anemia. Pernicious anemia is a condition in which vitamin B12 attaches to intrinsic acid, intrinsic factor, and then it gets absorbed within the lumen of the duodenum. So autoantibodies are formed against those intrinsic factor, which is like a transporter of vitamin B12. So this can cause vitamin B12 deficiency as well. This is pathophysiology, which I don't bother with because it doesn't matter in the exam. No question will be asked about this. Symptoms of anemia will be present, like fatigue, dyspnea. It can also cause glossitis, neurological symptoms, reversible dementia, and cognitive decline. Symptoms of subacute combined degeneration of the cord, especially lateral corticospinal, dorsal, and spinocerebellar tracts. So lateral corticospinal tracts will cause weakness, spasticity, hyperreflexia. Dr. Hima, please mute yourself. This is the third time I'm muting you, and it's. Can you please mute yourself? Thank you. Again, I'm requesting you guys, if you have any question, please ask on the chat box. It just disrupts the whole rhythm. All right, so lateral corticospinal tracts, we know these are the motor tracts. So weakness, spasticity, hyperreflexia. Dorsal column tracts, we know they are associated with vibration and proprioception. So vibration and proprioception sensations, if they are disturbed, then your balance is off. So gait difficulties will be present because of that, not because it is affecting your cerebellum. Spinocerebellar tracts will be affected, leading to gait difficulties, ataxia, and decreased proprioception sensation. So remember, guys, it does not affect the brain. It affects your spinal cord tracts. Okay. And 3 tracts. They can ask questions about what tracts are involved in subacute combined degeneration of the cord. So you have to remember the names of these tracts as well. Investigation, we do vitamin B12, peripheral blood film can show macrocytic megaloblastic anemia and hyper segmented neutrophil as well. So 1, 2, 3, 4, 5, 6 hypersegmented neutrophils. Can be folate anemia as well. Sometimes these two can occur side by side because folate anemia can also cause megaloblastic anemia, but it doesn't cause hypersegmentation of the neutrophils on peripheral blood film. Treatment is subacute degeneration, these three: lateral corticospinal, dorsal column, and spinocerebellar tracts. These three tracts are involved in subacute combined degeneration of the cord. Okay. So treatment is we have to give intramuscular vitamin B12 every weekly, then 2 weekly, then 2 weekly, then monthly, then 3 monthly. And then you can switch from intramuscular to oral dose, but intramuscular is quite well absorbed in the body. Irreversible neurological damage if untreated. Clear, guys? Any question? All right, let's move on to the next one. A man came asking about prostate disease. He had symptoms of urgency and urinary obstruction. You did a digital rectal examination. You felt a moderately enlarged prostate. Oh no, I don't know why I'm having a lot of tongue lisp today. Moderately enlarged prostate was found. Next most appropriate step of management in this patient is tell him about the pros and cons of test. I don't know what test. Do a prostatic specific antigen level, ultrasound of the prostate, or CT scan of the abdomen. So they haven't given us age. That would have been helpful. But they have given you a male who's coming with symptoms of enlarged prostate associated like urgency and urinary obstruction, right? DRE was done, you found a moderately enlarged prostate. What is the next step of management you do? All right, let me show you guys the guideline and then you can show me the answer. Are you guys able to see the screen clearly with the RACGP? Yeah, okay. So we know that this is a moderately enlarged prostate. All right. There could be, and the patient is presenting with lower urinary tract symptoms, like, for example, urgency, frequency, urinary obstruction, blah, blah, blah. We know about the differentials, right? It could be a UTI. It could be prostatitis. It could be a bladder calculi. It could be cystitis, urethral stricture, overactive bladder syndrome, prostate cancer, bladder cancer, urethral cancer, or BPH, right? If you have an elderly gentleman with other features mentioned in accordance with the prostatic symptoms, always think about neurological conditions like Parkinson's, stroke, multiple sclerosis, cerebral atrophy, head injury, spinal cord injury, or Cold-Icona syndrome, pelvic surgery. All right. Very important for you to do the history and examination. So in examination, the only thing that you do is the abdominal examination and DRE, right? So symptoms: incomplete emptying, frequency, intermittency, urgency, weak stream, straining, nocturia. These are the symptoms that can give you a clue about any problems with the prostate. These are the lower urinary tract symptoms, right? So examination is the digital rectal examination is always recommended because once you feel the smoothness of the prostate or nodular surface of the prostate, it can change your thinking about the differentials. So if you feel like a smooth enlarged prostate, you can still feel the medial sulcus. The first thing you will be thinking about is the benign prostatic enlargement, right? Or if you touch the prostate and patient is screaming in pain and the prostate feels like fluctuant, so you will be thinking about, oh, it can be prostatitis or it can be prostatic abscess as well. But if you feel a hard nodular surface, the first thing that should be crossing your mind is prostatic cancer. All right. So initial investigation, first investigation that you want to do is urine analysis. All right. Then you can check the serum creatinine or EGFR, which is RFTs, if you want to rule out any renal dysfunction. Then you can do a urinary tract ultrasound and do a PSA level to exclude prostatic cancer. Now come back to our question. A man came asking about prostate disease. He had symptoms of urgency and urinary obstruction. DRE was done. Moderately enlarged prostate was found. Next most appropriate step of management in this patient is we do an ultrasound of the prostate. Very good. Prostatic hypertrophy can happen in prostatitis as well, Dr. Urmi Roy. So you need to do all of the investigations, urine analysis, then RFTs, then ultrasound of the renal tract, like everything, not even the prostate. And then you can do a PSA just to make sure that we are not forgetting about the cancer as well. Is it clear, guys? Yes, ultrasound will. For example, BPH is a very homogeneous appearing prostate, whereas in cancer, it is a heterogeneous appearance of the ultrasound. PSA is not very specific because it can be raised in infection. So it will not, if you do a urine analysis and RFTs and ultrasound, and if you find everything is fine, then you will go towards PSA that maybe it's associated with cancer. PSA is not very specific for BPH. It will be raised in prostatitis. So if you are worried about infection, you will do the infective investigations first. If you are worried about BPH, you will do ultrasound. Everything if normal, then you would be worried about cancer, then you go towards the PSA. If its levels are high, then you can discuss with the urologist about next investigation. Yes, it can be, because if it is heterogeneous in appearance, it will give you an idea that you need to talk to a specialist like urologist about these findings. Clear, guys? Just give me 5 minutes. I'm just going to go and get some water. Give me 5 minutes. I'll be back. All right. Sorry about that. Is it clear, guys? Any question? For example, where's the question? A man came asking about prostate disease for a 68-year-old man. He had symptoms of lower urinary tract. DRE was done. Moderately enlarged prostate with hard nodules was found. Urine analysis and ultrasound is normal. What is your next best step of investigation? Or sometimes they will not give any talk about any imaging. We can say, for example, what can you say? For example, if it was 68 years, asking about prostate. Just give me 1 second, guys. I'll show you. You can't see the question? It shows that I'm sharing the same screen. All right. He wants to know about prostate cancer. Moderately enlarged hard prostate was found. Next most appropriate management of this patient. What can you do now? So what would be your answer here, guys? So your answer would be, no, don't do CT scan. What would be your answer? We will do PSA now. Is it clear? So they have not given you any imaging that we normally do for prostate, right? Right. So CT scan and CT IVP is not the imaging that we do for prostate. Prostatic cancer, unless we have like a PSA high, patient has symptoms of cancer like weight loss, anemic looking, very severe lower urinary tract symptoms. You have done examination, there's like a huge prostate and it's quite hard and you're worried about cancer, but none of the imaging is given in the question like ultrasound or urine analysis. You would do a PSA and then you will refer the patient to the urologist for the like a staging of the disease plus biopsy before that. If ultrasound was among these options, choose ultrasound first, please. All right. Okay. Next question. "85-year-old came to GP clinic with complaints of problems with recent memory. Number one is clue and location impairment, so getting lost. GP performed mini mental state examination and the score was 23 by 30. What do you tell her regarding her problem? It's a senile dementia, early Alzheimer, frontotemporal dementia, vascular dementia, or pseudodementia. Would 85-year-old will have Alzheimer's? Alzheimer's is a young age dementia. Alrighty. So if 85-year-old have recent memory problems and location impairment, does anyone know what is the normal MMSE score? Yes, more than 24. More than 24 is fine. So she's having mildly low MMSE score. That shows that she is having mild dementia. And they have given you no other clue other than her age. So what would be the most likely cause in the elderly patient of 85-year-old having mild dementia symptoms, it will be senile dementia, right? Age-related dementia. Around what age do we see Alzheimer's generally? 45. 45 to onwards, Alzheimer's can happen, especially in persons who have strong family history. 45 onwards, they're at risk of having Alzheimer onset. Everyone knows about Alzheimer's symptoms we have discussed yesterday. Anyone who wants me to repeat them, just let me know in the chat box and we can have a review of it quickly. Okay. So Alzheimer's disease. Alzheimer's disease, as we know, it's the most common cause of dementia after senile dementia. All right, and it's a neurodegenerative disorder in which there's amyloid proteins that gets deposited within the cerebral part of your brain. So it causes cognitive decline, memory decline, executive functioning decline, social and behavioral skills are affected because of your memory problems, and executive functioning, for example, decision making, keeping track of things, they all get affected at very later stage as well. It can get diagnosed early, especially on individuals who are at high risk with their family history. MRI is done, which can detect amyloid bodies within the brain, gray matter of the brain. Alrighty. Next one is frontotemporal. Frontotemporal dementia is the kind of dementia in which it's also a neurodegenerative process, guys. But it's much more rare than Alzheimer's, vascular, Parkinson's dementia, right? The only thing that I used to remember frontotemporal dementia is that frontotemporal dementia personality changes. So once a very introvert person will behave quite extrovertly, there will be social problems and behavioral problems in these patients as well. Disinhibition. So things which used to cause them to be a bit inhibited in their behaviors, they can drastically change. For example, Dr. Faryal has given a very good example. And they will lack insight in decision making as well. Next one is vascular dementia. Vascular dementia is the most common cause of dementia in patients who are having problems with their blood pressure. So hypertensive patients with risk for thromboembolic events, they have vascular dementia in which there is ischemic changes within the vessels of the brain. It can cause dementia. And it will again cause behavioral changes, problems with social interactions, and memory loss. Pseudodementia is it's very difficult to define pseudodementia because it's the kind of dementia, it's a disorder which mimics dementia. For example, if a person is having severe depression, it can cause them to forget things as well. So dementia can mimic that. Number two, psychosis can also mimic dementia, especially if a patient is having acute psychosis or recovering from psychosis. They can exhibit features of dementia, which is pseudodementia as well, but more commonly associated with depression rather than psychosis. So patients who have severe depression, they exhibit that. UTI in old people, Dr. Maha, it doesn't exhibit dementia. We call this condition as delirium, which is acute change in the orientation, alertness, and conscious level of the patient. So if there's an acute change in those three things, it can lead to a condition called delirium. Clear, guys? UTI, urinary retention, drugs, especially anticholinergics, sepsis of any kind, constipation, and these can all lead to delirium. Clear, guys? So these are the same links. Oh, Lewy body dementia. So Lewy body dementia is also a type of dementia, and it's a neurodegenerative disorder that has dementia features, plus visual hallucinations, auditory hallucinations, plus they have sign and symptoms of Parkinsonism as well. For example, resting tremors, bradykinesia, marked faces, shuffling gaits, urinary retention, and stuff. This is Lewy body dementia. So I always used to remember Lewy body dementia is Parkinsonism with dementia with hallucinations is Lewy body dementias. Clear, guys? We are running a bit late on time, but I'm happy that we went through that and it's clear. Okay, next question, relatively easy. 35-year-old man came from India, had joint pain, tenosynovitis, swollen joints. So pain in the joints, inflammation of the tendons, and swollen joints. Then they have a vesicular eruption on the arms. Platelet count was normal. What can be the provisional diagnosis? Reactive arthritis, gonococcal arthritis, HIV, or dengue? Joint pain, tenosynovitis, swollen joint, vesicular eruption. Vesicular eruption happens in dengue? I don't know about that. No, it doesn't. What kind of rash do we have in dengue? Dengue have what kind of petechial rash? Hemorrhagic rash. Yes, petechial rash. Because platelets are kaboom. All right. Joint pain, tenosynovitis, swollen joints, vesicular eruptions. It's not HIV. HIV doesn't present like that. HIV presents with symptoms of infection of the chest, throat, or abdomen associated with cervical lymphadenopathy, sometimes hepatomegaly or splenomegaly. It's gonococcal arthritis. Very good. Reactive arthritis happens after a STI infection, but this joint pain, tenosynovitis, swollen joints, and vesicular eruption on the hands is a gonococcal arthritis. This reactive arthritis is the kind of arthritis that happens after a chlamydial infection. So can't pee, can't see, can't climb trees. This is the triad of reactive arthritis. So urethritis, can't pee, can't see, conjunctivitis, can't climb trees is having arthritis. Okay, so this is gonococcal infection. Have a read of this. Gonococcal arthritis, because of the deposition of the circulating gonococcal immunoglobulin complexes. Risk factor is you can have virulence of gonorrhea, untreated gonococcal infection, if the patient is immunocompromised, SLE, female menstruation / pregnancy, low socioeconomic status, and educational status. So they can have polyarticular asymmetrical migratory arthralgias, tenosynovitis, and dermatitis. So tenosynovitis, we know it can be asymmetrical. Any joint tendon will be involved. And they have many types of dermatitis. It can be tiny maculopapular rashes. It can be pustular rashes. It can be vesicular regions with the erythematic bases on the trunk and extremities as well, but are most of the time painless. Okay. And sometimes if it's left untreated, it can cause a septic arthritis as well. So diagnosis is that we do gram staining of the gram-negative diplococci and culture, and we treat it with antibiotics. Clear, guys? In dengue, I agree with Dr. Herpy. Platelet count will be low, and symptoms in dengue is absolutely most of the time same, minus the rash which has been described here. So in dengue, you will have very high grade fever. Muscle aches and pains, retroorbital pain, very common. Um, what else? Sorry. Joint pains, very common. Petechial rash. And because when it's untreated, it can cause platelets to go kaboom. Then you can have bleeding as well. Nausea, vomiting, headache, these are prodromal symptoms. Yes, break bone fever. So lots of bony pain and retroorbital pain in dengue. It's not necessarily, but in hemorrhagic dengue, you can have black vomiting because of the GI bleed. Clear, guys? So this is how reactive arthritis presents. Causes, sorry, anterior uveitis, not conjunctivitis, my mistake. Anterior uveitis, inflammatory monoarthritis, and urethritis. And you can do like a PCR, not PCR on that. Any question, guys? Alrighty. A boy, 13-year-old, was brought to GP clinic by his father with complaints of knee pain. All examination is normal. There is tenderness over the tibial tuberosity and range of movements are normal. What is the provisional diagnosis? Traction apophysitis, pre-patellar bursitis, patellar tendonitis, or transient tenosynovitis? Tenderness over the tibial tuberosity, is it present in transient tenosynovitis? Very good, Dr. Kingsley. What's the other name that we use for Osgood-Schlatter syndrome? It could be, but less likely to cause tenderness over tibial tuberosity. Growing pains doesn't cause any tenderness when we press the bone. Osgood-Schlatter syndrome. The other name for Osgood-Schlatter syndrome is traction epiphysitis. Very good, guys. So this is Osgood-Schlatter syndrome. Pre-patellar bursitis is common in people who do jobs that require them to be on their knees most of the time. For example, carpet installers, tradies who work with concrete and needs to be on their knees all the time. They have pre-patellar bursitis. Less likely to be in a 13-year-old boy. 13-year-old boy would either present with, again, transient tenosynovitis of the hip after an infection, like upper respiratory tract infection or a abdominal GI infection, or they will have tenderness over tibial tuberosity because of excessive use. So traction apophysitis, traction on the apophyseal part of the joint will cause pain over the tibial tuberosity. So this is called Osgood-Schlatter syndrome. Yes, they can present with transient tenosynovitis in the knee. I agree with you, Dr. Sandro, but they will less likely have tenderness over tibial tuberosity. And their range of motion will be affected in transient tenosynovitis. They will not have full range of motion of their knees. All right, does that make sense? All righty. Let's go through this one by one quickly. Osgood-Schlatter disease, most frequent cause of knee pain in children from the age of 10 to 15 years. Pain and swelling over the tibial tubercle. It is very prominent and tender tibial tubercle. We don't need to do any investigations, but you can do plain radiographs to rule out red flags like neoplasm, acute tibial epiphyseal fracture or infection. GP doesn't do anything. We just reassure the parents that it's a self-limiting disease. Symptoms will resolve with the skeletal maturity. We can ask them to do like stretching exercises, modify their exercise activities to manage the pain. They can use local measures like eyes, anti-inflammatories, and quadriceps stretching to reduce the pain. If the symptoms are not resolving and persisting for more than 18 months, then we need to do a specialist referral to make sure that we are not missing anything. Prepatellar bursitis. Where do I shut this one? All right. We know that it's the inflammation of the bursa on top of the patella. It's because of constant compression of the bursa between the patella and the hard surface. For example, kneeling down a lot. A direct blow can also cause it, for example, in a trauma. For example, in football, wrestling, basketball players, other peoples who are more susceptible to cause inflammation of their bursa in the patellar region is those who have rheumatoid arthritis, gout, or osteoarthritis as well. It can also be caused by a bacterial infection. So it's quite enlarged. I have seen that in my life. It's similarly swollen like this patient's knee. Pain with activity, rapid swelling of the kneecap, tenderness and very warm to touch. But you need to make sure that there is no infection and they don't have systemic features. You do a x-ray, you can do a blood test, or you do aspiration if you're concerned about the septic arthritis. Again, treatment is basically the same. We do activity modification, we apply ice, elevation, and SIDS. So for every orthopedic condition, they have a mnemonic that is used for management, which is pain relief, rest, ice, compression, elevation. So they use it in most of the things, and they can help to decrease the severity of the pain and the occurrence of the pain as well. Clear, guys? Any question from there? All right. I have given another link for Victorian health information on Osgood-Schlatter syndrome. It's basically the same as which was discussed by the Royal College of Children's Hospital. Okay, let's move on to the next question. Um, can an old batch student get this questions file in their portal? Certainly, Dr. RH, you will get these in your portal as well. All right. Next question, guys. A man comes for refugee camp health screening. He has taken 1 dose of albendazole before coming. On lab investigation, he still have persistent eosinophilia. No other abnormality present. He doesn't mention any bowel symptoms. What do you want to check for investigation? Ova in stool, skin prick, endoscopy, or blood test again? So we know this is a patient who has immigrated and is coming to refugee camp for a health screen, has eosinophilia, but has only 1 dose of albendazole, which is an anti-parasite, before coming. And we want to doesn't have any bowel symptoms yet, but lab investigation shows that he has eosinophilia. So we will check his stool for ova to make sure there is no protozoal infection. Very good, guys. Doing a blood test again will not give us more information. Endoscopy is not required to do at this point because can anyone tell me what are the indications of endoscopy? So upper GI bleed, persistent GERD symptoms, not responding to PPI therapy, dysphagia, patients who are having anemia in 40 and above, and gastric outlet obstructive symptoms, plus prodromal symptoms for cancer as well. Okay, so we do endoscopy in those. Skin prick test is done in allergies. When a patient has a history of eczema, asthma, or food allergy, we can refer them to an immunologist who can do skin prick test to make sure to find out what sort of allergies they have or to which substance they're more allergic to. Very good, doctor. Esophageal viruses as well. Okay. You guys can find refugee health screening from this particular link. I haven't found anything in the JM regarding refugee health screening, so it's a good one that you can use. It's Australian Refugee Health Practice Guideline. Okay, so let me just increase the size so it's easier for you guys. So they have given a table of contents that you can go through. But the key points is that we need to make sure we are not missing major diseases, mental and physical in them. And make sure they don't have an infectious disease that can spread in the community if left untreated. All right. Medical history, especially history of tuberculosis, hepatitis B, C, HIV, STIs, respiratory GI, systemic localizing symptoms, immunization status, chronic non-communicable diseases like cardiovascular disease, chronic obstructive disease, thyroid problems, hearing, vision, dental problems, anything that can lead to normal functioning of their life. Lifestyle risk factors as well. Nutrition and risk factors for vitamin D is very, very common. All right, psychosocial history for their mental health being physical examination. What are the investigations that we do? So we do a full blood count, hepatitis B serology, hepatitis C serology, strongyloid serology, HIV serology, TB serology, varicella, rubella, fasting glucose, HbA1c, fasting lipids, ferritin, vitamin D, vitamin B12, syphilis serology, first pass urine for STIs, helicobacter antigen, stool microscopy. If no documented pre-departure albendazole or persisting eosinophilia after albendazole treatment, we should consider doing a stool microscopy. Yes, you do need to go through all of this, Dr. Tabinda. They do ask questions from here. And schistosomiasis, especially those who are coming from Middle East countries and African countries, and malaria, thick and thin films with malaria RDT. Most of the time, thick and thin films are done. Alrighty. Any question, guys? No. Okay. How about we take a 5-minute break and then we can continue with the rest of the slides. Okay. Let's take a 5 minutes break and we'll come back and finish this one. Persistent eosinophilia means that there is something within the body that is causing an immune response leading to release of IgE or allergy, right? Skin prick is the test immunologists do to find out what sort of allergy the patient is having. Yes, you will get all of these theories again in the theory class. Welcome back, everyone. Let's resume. How can we get access to these portals? You have to subscribe to the course, and then you will be able to get access. All right, let's continue. A middle-aged female presented to a GP clinic with complaints of right hand thumb and index finger weakness. Improved when raising the arm above the head with mild thin arm muscle wasting. Brachioradialis jerk is less in power. Also complains of neck pain. What is your provisional diagnosis? Cervical radiculopathy, carpal tunnel syndrome, thoracic outlet obstruction, cubital tunnel syndrome, Pencost tumor. So this patient is having right hand, thumb, and index finger weakness, which is improved when she raised the arm above head. There is mild wasting of the thin arm muscles. Brachioradialis jerk is lesser in power. Also complaining of pain in the neck. So this is carpal tunnel syndrome will only have like median nerve weakness, right? So there will be thin arm muscle weakness, also weakness of the muscles innervated by the median nerve. Also, it will affect the sensations as well. So the thumb, index finger, middle finger half will, middle finger and ring finger on the half will be affected or have some decreased sensation. Brachioradialis jerk or reflex will not be affected in carpal tunnel syndrome because carpal tunnel syndrome is it's the pinching of the nerve at the level of the flexor retinaculum, right? So less likely to be the cause. Thoracic outlet obstruction will have completely different feature. So thoracic outlet syndrome is a group of disorders. It's not just a single disease. It's a group of disorders when when a bunch of nerves and blood vessels are compressed in our thoracic cavity or mediastinum. It affects the space, usually the space between your collarbone and the thoracic outlet, which is the first rib. So this is your collarbone and this is your first rib from the sternum. So the space between them, it will be affected and they have major vessels and nerves passing through it. It can be caused by trauma. It can be caused by the penetrating injuries. It can be caused by compression injuries, sometimes in pregnancy as well, or sometimes the cervical rib presence, it can cause that. And it will cause like symptoms of pain in the shoulders. It can cause pain in your neck, numbness, weakness, and coldness in your fingers, numbness, weakness of your arm or forearm. So it can cause pain anywhere along brachial plexus distribution. So less likely to be present. Cubital tunnel syndrome is similar to carpal tunnel syndrome, but cubital fossa is our fossa in the arm at the elbow region. So they will compress the brachial artery. And which nerve will be affected in cubital tunnel syndrome, guys? Very good. Ulnar nerve will be affected. So instead of thumb and index finger, your little finger and ring finger will be affected. Okay. Pencost tumor, so less likely to be cubital tunnel syndrome. Pencost tumor is it's a tumor of the apex of the lungs, which can compress. It's a rare problem. It's the apex of the tumor that compresses the nearby tissues of the ribs and vertebra. So it can present with Horner syndrome, right? Pencost tumor can present with symptoms of Horner syndrome. Can anyone tell me what are the symptoms of Horner syndrome? So it will cause, yes, meiosis, ptosis, and hydrosis, and Anhydrous, very good. And also because it's present in the area where brachial plexus is passing just behind the apex of the lung, it can present with tingling, numbness, and weakness of the arm or distribution of the brachial plexus as well. Clear, guys? Any question? So your correct answer is cervical radiculopathy. Option A. Any queries, guys? Is it clear how our answer is A? Alrighty. Can you again tell difference between Horner and Pancoast syndrome? Look, the difference between Horner and Pancoast syndrome is that it is a part of the Pancoast tumor. So if Pancoast tumor is suppressing a ganglion, it can cause, let me just quickly bring up the Pancoast tumor Horner syndrome distribution. When you have Pancoast tumor, it can affect one of the ganglions that leads to our, especially the third nerve. So it can present with meiosis, ptosis, and hydrosis. It's cervical sympathetic nerve compression, basically. Thenar muscle weakness does occur in carpal tunnel syndrome. In Pancoast tumor, just remember, guys, there will be ipsilateral Horner syndrome. So if it's because it's on one side and it's compressing the cervical sympathetic nerves on one side, it can cause ipsilateral Horner syndrome. Again, it's compressing the brachial plexus on one side, so ipsilateral paresthesia and weakness on one side. Again, because it's present within the thoracic cavity and the laryngeal nerve is passing just behind it, it can compress that and cause hoarseness. And sometimes it can compress your superior vena cava as well and can cause superior vena cava syndrome as well. Is it clear? Alrighty. So cervical radiculopathy and myelopathy. Radiculopathy is when the spinal cord nerves are compressed when they pass through the foramina, and it will present with symptoms of lower motor neuron signs. Just give me 1 second. I'm just going to mute everyone. And myelopathy is when the cervical part of the spinal cord is compressed, and at that level you will have upper motor neuron signs. Is it clear? I have just given this for your information. All right. Next question. A patient came to GP clinic with erectile dysfunction. Also have depression, emphysema, which is chronic obstructive pulmonary disease, hypertension, history of myocardial infarction, heavy smoking of more than 40 per day, alcoholic. Most appropriate initial management for all the diseases, especially erectile function, would be which of the following? Sildenafil, cease smoking, cease alcohol, increase dose of hypertensive drug, or stop perindopril. So a patient has erectile function but has different comorbidities as well. They are asking for initial management that can help with the management of the rest of the diseases as well. That would be very good. So we will ask them to cease smoking. Very good. Sildenafil can sometimes have a very bad effect on patients with myocardial infarction, especially if they have inferior myocardial infarction, because it can cause reflex bradycardias in them. So it's a big no-no. Ceasing alcohol can help, but erectile dysfunction is more associated with smoking rather than alcohol consumption. Um, and smoking again is a big risk factor for atherosclerotic diseases that leads to thromboembolism like myocardial infarction and strokes. Increased dose of hypertension drug can help, but it will not help in resolving or in the management of erectile dysfunction. It can cause erectile dysfunction, but it's less likely to be the cause, most likely to be the cause by heavy smoking. Um, Stop perindopril. If the patient is on perindopril and responsive to that, there is no indication to stop them, even if the patient has erectile dysfunction, because it doesn't cause any problems with erectile dysfunction. Alrighty. So our answer is cease smoking. Everyone agrees with that? Any question, any queries you have regarding that about why B is the answer? No? Okay. Erectile dysfunction in RSCGP, risk factors, advanced age, atherosclerotic diseases, neurological diseases like Alzheimer's, multiple sclerosis, Parkinson's, strokes. My voice is not audible clearly. Let me just wear both of my headphones. Is it clear, guys? Are you able to hear me clearly? Okay. Peripheral nerve disorders, pelvic surgeries, endocrinological disorders, especially hypogonadism, hyperprolactinemia, thyroid, obesity, major cause after cardiovascular risk disease factors, atherosclerotic ones, metabolic syndrome, penile abnormalities, rare causes, psychiatric and psychological, the most common cause after the most common cause, not after atherosclerotic one, the most common cause of erectile dysfunction. Medications like antihypertensives, diuretic alpha and beta blockers, psychotropic medication, especially SSRIs, anticonvulsants, anti-Parkinsonism agents, and hormone affecting ones, alcohol, illicit drugs, erectile dysfunction associated with other sexual dysfunction, for example, rapid ejaculation. History, you've done examination, investigation would be dependent. Treatment, lifestyle such as diabetes, hypertension, smoking, dyslipidemia should be optimized. And then you can go towards the pharmacological and psychological treatment. What else? Initial discussion, very important to know about what is their information about erectile dysfunction and what they think erectile dysfunction is. Evaluation of their risk, physical examination, blood test you can do if you think it's a hormonal problem, or if you think that the atherosclerotic disease might be contributing towards that. Optimize modifiable risk factors first in your treatment. For example, in your lifestyle, quit smoking, healthy diet, exercise, reduce alcohol intake, and avoid recreational drug. Reinforce blood pressure, dyslipidemia, and diabetes control. Assess for cardiovascular causes. And then you can treat reversible causes like low testosterone, medication-induced erectile dysfunction, psychogenic, by referral to a therapist. After doing all of that, your first line medication should be phosphodiesterase type 5 inhibitor, and then refer to a urologist for second line and third line therapies. Your job as a GP will not be to prescribe these two things. This will be the urologist's job. You will do the first line. If he's not getting better, then refer to urologist. Clear, guys? Alrighty. I'm going a bit fast now because we're a bit short on time. A lady was taking olanzapine and stable with that. But sometime later, she complains about weight gain. Her BMI is 40. Which one of the following would you give her now? Risperidone, clozapine, aripiprazole, quetiapine, or haloperidol? Okay, this is a bit of a tricky question. Let me open something that can help you guys decide. Okay, greater weight gain during the first month of antipsychotics. Olanzapine, higher risk of weight gain. Clozapine, higher risk. So we know clozapine is out from our game. What is the next one? Chlorpromazine, gone. Quetiapine, medium risk. So quetiapine plus minus. Risperidone plus minus. Paliperidone, medium, which have low risk. Esinapiane, amisulpiride, aripiprazole, lurasidone, ziprasidone, and haloperidol, right? So let's go back to our question. We know that risperidone moderate risk, clozapine high risk, quetiapine moderate risk. We have aripiprazole and haloperidol. Do we usually put patient on first generation antipsychotics when they are stable on second generation antipsychotics? No, we always use the second generation one. So your correct answer in this would be aripiprazole. Haloperidol is associated with a lot of side effects, so we don't use it. We only use it in acutely psychotic patients. First generation antipsychotics are not used for patients unless they have refractory problems requiring it. Okay, clear guys? Any question? Yes, we use in acute cases. Droperidol is the drug that is used in Australia for acute management of psychosis or aggression, agitation. A patient is coming with, want to see the source. Okay. Just quickly going back for Dr. Urmi. This one, BAP. It is, you can also, Dr. Urmi, if you write Royal Australian and New Zealand College of Psychiatry, you will find a huge booklet that will have everything written on it, like every, let me just show you guys that source. Royal Australian and New Zealand College of Psychiatry for antipsychotics. There is an image that I want you guys to remember. Where is that? This one. I think, no, not this one. There is a whole table in that guide. That is a guideline book for psychiatrists. It's there. Royal Australian and New Zealand College. This one. This one, Dr. Urmi. So clinical guidelines, and you can explore by topics as well. It has everything written in the form of table if you need, okay? All right, next question. A patient is coming with intense photophobia, painful red eyes, but pupils are acting normally. What is the provisional diagnosis? Keratitis, glaucoma, foreign body, or conjunctivitis? So photophobia, painful red eyes, but pupils are okay. Just photophobia and painful red eyes. So this is very, very common disease. Very good, everyone. This is conjunctivitis. Keratitis, your pupils will be affected. And sometimes, if it's quite severe, your vision will be affected as well. In conjunctivitis, pupils' vision is not affected. Foreign body can cause intense photophobia, painful red eye, vision effect as well. Glaucoma, your pupil will be not reactive to light, and there will be hazy cornea, dilated pupil, lethargic response towards the light as well. Okay, again, Royal Australian College of General Practitioner, every eye disease in the form of they can mention tear lacrimation, increased lacrimation. So viral conjunctivitis will not have any purulent discharge. They will have increased lacrimation. Okay. Where is your viral conjunctivitis? Bilateral conjunctival inflammation, chemosis, eye swelling, periauricular lymphadenopathy, small corneal, sterile infiltrates. Very common, self-resolving. If you have keratitis, reduced vision, photophobia, and on fluorescein dye, you have dendritic patterns. Foreign body, inciting event, foreign body sensation, visual foreign body on the cornea and conjunctiva that will cause problems with the vision. Bacterial conjunctivitis, conjunctival inflammation, sticky discharge, cornea clear with no infiltrate, so no problems with the vision. This is dye. Itching allergic conjunctivitis will be having like conjunctivitis with lacrimation. Yes, it can cause photophobia. Blunt trauma, conjunctival inflammation, subconjunctival hemorrhage, and you can see hyphema as well. Uveitis, anterior chamber infection. So your pupil will be deformed, photophobia will be there, reduced vision will be there, the conjunctiva will be red, ciliary inflammation will be there. You can sometimes see hypopyon, which is a pus in the interior chamber. Yes, you guys should learn all of it. Yes, sorry, you need to learn about this. Okay. So corneal problems, anterior chamber problems, scleral problems, eyelid problems, eyelashes problems. You need to know about each and every one of them. Acute glaucoma, severe pain, vision loss, nausea, vomiting, headache, cloudy cornea, fixed pupil, high eye pressure. All right, what else? All righty, that's about it. Yes, it will be taught, Dr. Ziomi. It will be taught. Don't worry about it. Alrighty. You have done cerebral spinal fluid culture sensitivity or just cytology. You can find Dr. Bushra if you type RACGP eye conditions. You can find it on the Google. It takes a lot of time if I just copy paste from my notes as well. So you have done a cerebral spinal fluid cytology. Your glucose is normal, but polymorph nucleosides is quite high. What is the antibiotic of choice? Ceftriaxone, ampicillin, gentamicin, or acyclovir? Incomplete, but they have given you a big clue over here. Polymorph nucleosides are high. And they have asked you what antibiotic of choice. Why are you going towards antiviral? If they are asking you antibiotic of choice, don't even think about antiviral. But look at the question, what antibiotic of choice? So option D is gone. So what do we use in meningitis? Empirical antibiotic is ceftriaxone. Very good. Can anyone tell me why do we use ampicillin in children less than 2 months of age? Why do we use ampicillin instead of ceftriaxone? Very good for Listeria monocytes. Very good. A bit of information about your CSF. Normally in exam, they will give you all of the information. It won't be incomplete like that. Clear, guys? Next question. A young male, 24 years of age, presented to emergency department with chest pain, which is now better. On chest x-ray, pneumothorax is 15%. What do you want to do next? Admit and observe, come back the next day, needle aspiration, or chest intubation? So 15% spontaneous pneumothorax on the chest x-ray. What do you want to do? You want to admit and observe the patient. If it's not resolving or if the patient is becoming hemodynamically unstable, then we need to do needle aspiration in them. Very good, Dr. Huang. Ma'am, I think the previous question, it can be keratitis. Dr. Huang, in keratitis, I agree, you have photophobia, you have a painful red eye, but your vision is also affected in keratitis because it's a corneal inflammation. All right. This is New South Wales emergency guideline for spontaneous pneumothorax management. Very well written. Why not C? He had chest pain, which is better. So resolving chest pain and is stable on hemodynamics. They haven't given you any information that, oh, he's requiring oxygen, his chest pain is not getting better. If there's something like that, I agree with you completely. We will go straight towards needle aspiration. We have to do serial x-rays. Yes, it can be stabilized and resolved on its own. Not in all of the cases, we do needle aspiration. So there are different types of it.
Oh my God.
Is anything wrong? Galaxy A22, is anything the matter? Alrighty. So we know spontaneous pneumothorax, it can be primary, that happens on its own. It can be secondary, which means it has been caused because of an underlying lung condition. Patient can have ipsilateral chest pain, sudden onset of shortness of breath, anxiety, cough, and vague
Travel
chest
को तो कोई
symptoms can
समझाया ही नहीं है जो वैसे ही कह रहा है कि मैं मसरूफ हूँ।
Signs can be based on hemodynamic stability, can range from normal to diaphoretic and unwell. For example, if this was in our question and patient was getting diaphoretic unwell, chest pain has resolved but still persisting diaphoresis, shortness of breath, please go towards needle aspiration. Focal signs, decreased lung expansion, absent or decreased breath sound, hyporesonance or percussion. Severe symptoms can cause respiratory and cardiovascular distress as well. For example, like cyanosis, sweating, severe tachypnea, tachycardia, and hypotension. These are all the signs of tension pneumothorax. Tension pneumothorax requires immediate needle compression followed by a chest tube insertion with a water drain. Okay? Water under seal. Diagnosis is you can do a bedside ultrasound, but most appropriate you do a erect chest X-ray. CT scan can be done for complex cases. All right. Management. Determine the size. If it is a large or small, if it is more than 2 centimeter, then it's a large one. If it is less than 2 or equal to 2 with no symptoms, it can be treated as only by doing observation. Where is treatment? This was the size. This is the treatment option. Sorry. All right. Observation treatment choice for small without significant breathlessness. Can you please appreciate that? But patients can be considered for discharge with early outpatient review, provided they can seek emergency in case of worsening breathlessness. So if you think that this is symptomatic, even though it's small, then please go ahead with needle aspiration. But if it is large, then you need, or patient is requiring oxygen, you need to immediately do a needle aspiration. Secondary pneumothorax, doesn't matter the size, requires admission and needle aspiration. Sometimes when the needle aspiration is not working, the next thing we do is the chest tube insertion. Okay. Pneumothorax can happen, reoccur very well as well. So these patients should be given information that you're not supposed to fly in an aeroplane, no scuba diving, no skydiving. And in the next 24 hours, if we are sending them home, in secondary, doesn't matter the size, all needs needle aspirations. If needle aspirations are not working, or if it's an extremely large size, chest drain. Alrighty, any question, guys? Secondary, if the patient have asthma, chronic obstructive pulmonary disease, cystic fibrosis, bronchiectasis, things like that. GP has cognitive impairment on treatment, but also seeing patients. What do you want to do next? Inform AFRA, talk to GP, inform a principal body, or monitor action. So cognitive impairment while on treatment, but also seeing patients. What do you want to do next? Let me show you guys. The notifiable offenses to AFRA. All right. Impairment, intoxication while practicing. Impairment doesn't matter. Cognitive impairment, physical, mental impairment, significant departure from accepted professional standards, and sexual misconducts. These are all notifiable. So what do you do next? Who is the principal body that you inform? You inform AFRA. They will investigate. It's not like you're snitching on your colleague. You're making sure that this colleague is not putting the patients at risk. It's not snitching on somebody. Making a notifying AFRA doesn't mean that you're causing that GP to lose their license. It is something that AFRA will decide after doing investigation. They don't. Yes, because they are on treatment, maybe they will give them some leniency, but impairment of any kind requires notifying to the authorities. In which case, in our case, it's AFRA. All right. A man came with back pain, mild tenderness over sacroiliac joint. X-ray shows early inflammatory changes. HLA-B27 is positive. Apart from physiotherapy, what can you do? Biological agent, naproxen, give steroids, give sulfasalazine or paracetamol. So what is this disease, guys? Back pain in a HLA-B serotonin positive ankylosis spondylitis. So in ankylosis spondylitis, again, yes, physiotherapy is very important, but how do we manage the back pain with the initial agent? We will give steroids. Very good. So this was a very easy question. I'm just going to breeze through that very quickly. Alrighty. Next one. Any queries, anyone? Steroids are not used for initial management of the pain, Dr. Huang. Naproxen. NSAID. I should have clarified, sorry. Non-steroidal anti-inflammatory agents, guys. Alrighty. A young male was brought to emergency department with snake bite, no fang marks, but there is a linear scar. What do you want to do next? Very common happening in Australia because of lots of snakes here, and most of them are poisonous. Take a swab and do a pressure bandage, anti-venom kit, transfer to hospital, serve anti-venom. So initial management of a snake bite is, yes, transfer to hospital is a must. What do you do next means they're asking about initial management. Next thing is we do a pressure bandage and swabbing. And then transfer them to the tertiary hospital. After taking bloods, you need to take bloods as well. So history of possible snake bite, needs to observe in a critical care area. Again, you guys are absolutely right that this should be transferred to the tertiary care part. Before doing that, we apply pressure immobilization bandage if not already present. Then we evaluate if we are already in I don't know what they want to do the swap for, to be very honest, but it's with the option that is most likely the answer. That's why I would go with pressure bandage. I don't know what the swab is for, to be honest. It's weird. So after applying the PIB, we evaluate for clinical signs of envenomation. If you don't have any neurological signs, hematological signs of envenomation, then you apply topical anesthetics prior to inserting IV, and we take blood test, complete blood count, chemistry, and coagulation profile. If there is a lab evidence of envenomation, for example, your liver function tests are deranged, coagulation profile is deranged, then you consult the toxicologist and you try to give the antivenom or antivenom to the patient. Okay. If there are clinical signs of envenomation, then we give 2 IV large bore, take bloods, resuscitate the patient if required, consult with the toxicologist. Because antivenom causes a lot of anaphylaxis, you should be prepared for anaphylactic reaction. Give antivenom, and once we give the antivenom, we have to release the pressure immobilization bandage, right? So admit the patient for observation. In the non-clinical signs of envenomation and lab investigation doesn't show any signs of envenomation, what do we do is that after some time, we release the pressure immobilization bandage. We repeat the neurological examination. We do a blood test post removal of the antibiotics first, then 6 hours, then 12 hours. If all of the investigations are normal, we discharge them. Clear, guys? This is RCH. And this is New South Wales. Both are absolutely the same. So we will apply bandage first, transfer to the hospital, do lab investigation or assess for signs of envenomation. No signs, lab investigation, signs, do resuscitation and do blood test and give antivenom. If no signs, Then you lab investigation. Lab investigations are normal. Release the pressure immobilization bandage. Do the examination again and repeat the blood test 1 hour, 6 hour, 12 hours after removing the bandage. Another question similar to this one. Same question. No signs of envenomation, but punched out fang lesions are present. Presented after 30 minutes, he is wearing jeans and there is signs of bite marks from it. What will you do next? Admit, observe, and give antivenom at 12 hours. Discharge antivenom right away. Lab investigation after 24 hours of the bite. So we know that we won't discharge this patient, right? This is a very tricky question, guys. None of the options are correct, but we need to find the option that is most close to the answer. We won't discharge this person right away, right? We know about that. We all agree. Do we give antivenom right away with no clinical signs of envenomation? No, right? So option C is gone. Do we do lab investigations after 24 hours of the bite? No. So most possible answer is answer A. We do admit them and we do observe them, but it's not necessary that we give antivenom after 12 hours. Okay? So these type of questions, I'm afraid, do come into your exam as well. These type of questions do come in your exam. It was just a preview I wanted to give you guys. Alrighty. Next question. Let's do something easy so that you guys get a bit relaxed. Polycythemia rubra vera. Yes, antivenom is present if there are clinical signs of envenomation or if your lab investigation shows that there is chemistry signs of envenomation. Then you can give antivenom. Polycythemia rubra vera. What is the physical examination finding? Splenomegaly, most common one they're asking. Cardiomegaly, purpura, opaque eyes, or joint pain. Yes, that is why they have said in the guideline that you need to be prepared for anaphylaxis. So most common finding of polycythemia rubra vera, guys. Alrighty. Sorry. Alrighty, let's start. So polycythemia rubra vera, we all know it's increased amount of red blood cells in the body. And it causes elevated hemoglobin, right? It can cause joint pain. Most of the time it's called chest pain, not joint pain acutely. So less likely. All right. Next thing is polycythemia doesn't cause opaque eyes. Okay, it doesn't cause opaque eyes. It's not one of the symptoms of it. It can cause rash, but does it cause purpura or does it cause bruises and petechiae? Can anyone tell me? What does it cause? Bruises or petechiae or purpuras? Very good, Dr. Maria. It causes petechiae and bruises. Cardiomegaly is a physical examination finding of polycythemia rubra vera, but it's a late physical examination finding and it's a complication of it. So most common physical examination finding out of these is splenomegaly. It can also cause spleen liver enlargement as well. It's not just spleen that is enlarged. Have a look at this. Fatigue, headache, dizziness, blurred vision doesn't cause opaque eyes. Um, so mucosal cyanosis, bruising, petechiae, enlarged spleen or liver. These are the most common clinical signs or examination findings of polycythemia rubra vera. We know it's overproduction of red blood cell and increased erythropoietin. We have to do phlebotomy because the blood is so viscous, it's so thick, it can cause heart attacks as well. So we need to make sure that we are taking out the blood by doing phlebotomy, increase the fluid intake. We give aspirin, which is antiplatelet, and myelosuppressive agents to prevent this overproduction of the RBCs as well. If we had both splenomegaly and hepatomegaly, then what to choose? Splenomegaly. So spleen is the biggest lymphoid organ. It causes so when there's increased production of the immature RBCs, it will clear it out and it will be enlarged in the first place rather than hepatomegaly. Okay. Alrighty. A patient, gravida 2, para 1, previous scar for breach under GA. This time, she presented 39 weeks, placenta previa, and undergo planned cesarean section under GA. Otherwise, antenatally, no other problems. Immediate upon delivery of the baby, blood pressure dropped. There was profuse bleeding. It couldn't clot. Pulse rate was also low. What could be the cause to her emergency condition? Anaphylaxis to an anesthesiological medication, amniotic fluid embolism, retained placenta, uterine inversion, or extended scar to uterosacral ligament. So immediate after the birth of the baby, the blood pressure dropped. Huge amount of bleeding. No clotting, not clotting. So pulse also dropped. Bradycardia. Bradycardia with hypotension. It's a sign of retained placenta. Is it? Profuse bleeding, I agree. Hypotension, I agree. Should be having tachycardia instead of bradycardia. It's DIC. Very good, Dr. Sapphire. DIC happens in which of the following conditions? Amniotic fluid embolism. Yes. Very good. So this is amniotic fluid embolism. We know that amniotic fluid embolism is basically amniotic fluid emboli going into the mother's bloodstream. Okay? Most leading cause of direct maternal death in Australia. Okay? It's a presumptive diagnosis. There is no risk factors to establish it. There is no diagnostic definitive test as well. Acute hypotension or cardiac arrest, acute hypoxia, coagulopathy with severe hemorrhage at the birth of the baby is the diagnosis for acute amniotic fluid emboli. Or woman with the diagnosis is made in the postpartum examination because the findings of the fecal squamous or hires were found in their lungs. So high mortality associated. So you need to have high suspicion. Whenever the baby is born and mother goes bradycardic, hypotensive with profuse bleeding, which is not clotting. Not clotting is a big indication that there is DIC and that there is a coagulopathy going on. So you need to be very, very conscious about this being a amniotic fluid embolism. Management is that you resuscitate airway breathing circulation, platelet supports. It's a supportive management basically. You try to treat hypotension, you try to treat coagulopathy. You make sure that you are having fluids in her body to maintain her blood pressure as well. If it is clotted blood, then go for placenta, retained placenta. If there is no DIC, then it's not amniotic fluid embolism, less likely. Okay? Clear, guys? We are 15 minutes up. Let's quickly finish this. A patient was brought to surgery department with diabetic foot ulcer. What's the next investigation after antibiotics given and debridement was done? Doppler, venous, scintigraphy, X-ray, or MRI? We have discussed this. I think I remember discussing it with you guys yesterday as well. In diabetic foot ulcer, what is the first imaging that we do to rule out osteomyelitis? It's the X-ray. If there are findings on the X-ray, that might indicate that there are signs for osteomyelitis, then what is the next imaging we do? MRI. Very good, guys. So that is all for today, everyone. I hope you had a good session and I was able to help you guys. When would we do Doppler? When you think that patient with diabetic foot ulcer has associated peripheral vascular disease, then you will do Doppler. Thank you, everyone. I hope you had a wonderful session with me. And I hope to see you guys in the course as well so that we can help you get equipped with the knowledge to help you pass the exam, which is a wonderful journey to work in one of the best health systems in the world. So study well, try to stick to the John Murtagan guidelines and try to make sure that you have a good grip on your basics. And this will eventually help you to pass the exam. All right. Thank you, everyone. Hope you have a wonderful night. This is the last free session. The next class will be for those who have subscribed to the course. Okay? So we will always give a schedule in the course Facebook page. Don't get overwhelmed, Dr. Termina. Slowly, you will get used to a lot of information and your brain will absorb it. So I know this can seem very overwhelming, but when you go system by system and you try to read everything, everything will make sense in the end. All right. Thank you so much, everyone. Have a good night.